Okay, I'm going to start letting people in now, and Dr. Lemry, you can start right at the top of the hour.
Okay, thanks. Good evening, everyone. My name is Dr. William Lumry, and I'd like to welcome you to our webinar, Evolving Strategies for the Management of Hereditary Angioedema, a patient-centered approach with real-world examples. This webinar is provided by Integrity Continuing Education, LLC, and was supported by an unrestricted educational grant from Takeda Pharmaceuticals. I'm a clinical professor of internal medicine at the University of Texas Southwestern Medical School, a medical director of AARA Research Center, and in private practice in Dallas, Texas. My disclosures are listed here. As you can see, I'm multiply conflicted, which means I'm fair with everybody. I'm joined by Dr. Nicholas Kolinsky. Nick, would you like to introduce yourself, please?
Sure. Thank you so much, Dr. Lumry. So I'm Nicholas Kolinsky. I work in Knoxville, Tennessee at the Allergy, Asthma, and Immunology Center, and I'm the president of the Tennessee Society of Allergy, Asthma, and Immunology. It's great to be here. Thank you.
Thanks, Nick. Well, we're looking forward to a packed hour of information about hereditary angioedema. Our learning objectives, as you can see on the screen, are to apply guideline recommended strategies to accurately identify patients with hereditary angioedema, which we'll be referring to as HAE. We're going to analyze and compare the approved and emerging treatment options for managing HAE effectively, both treating attacks as well as preventing attacks, and utilize shared decision-making and validated assessment tools in the development of treatment plans for patients with HAE. So first, we're going to talk about the disease, hereditary angioedema. As you are aware, hereditary angioedema is a rare and potentially life-threatening disorder characterized by unpredictable episodes of swelling. These attacks can affect the skin, the gastrointestinal tract, and the upper airway, the latter being potentially life-threatening due to asphyxiation if not recognized and treated. Timely recognition and appropriate management are obviously essential in improving patient outcomes. So how does this disease present? It's episodic, unpredictable, recurring episodes of non-pruritic, non-pitting, subcutaneous, and submucosal swelling. A key feature is urticaria and itching are not a piece of this disease, as it often is with mast cell-mediated or allergic angioedema. There's a family history often. It's an autosomal dominant genetic disorder. So if you have hereditary angioedema, there's a 50-50 chance of each of your offspring having the disease. There are a variety of subtypes. The most common are hereditary angioedema type 1 or type 2, which are associated with a deficiency in C1 inhibitor, a regulatory protein of the contact system, or a dysfunctional protein, but the net is they don't have enough active and functioning C1 inhibitor to regulate that system. Another form that has been identified in the last 25 years is hereditary with angioedema with normal C1 inhibitor. These individuals, as stated, have normal C1 inhibitor and normal other laboratory in the complement system, but they present with similar symptoms as do individuals with type 1 or type 2. The attacks that these individuals experience are variable in onset, but the majority develop over hours, as opposed to a mast cell-mediated angioedema, which may occur over a matter of minutes after the antigen or the trigger has been encountered. They're also often prolonged, sometimes lasting as long as 5 days if they're not recognized and treated early in the course of the swelling episode. A key feature in taking a history of these individuals is their lack of responsiveness to antihistamines, to corticosteroids or epinephrine, as opposed to mast cell-mediated disease, again, a much more common form of angioedema. They're unpredictable, and this unpredictable nature of the disease is actually what is most disabling about it and most bothersome to these patients, creating a significant burden both for the patient as well as their caregivers. There are a variety of triggers, and across the HAE population, the frequency, severity, and type of swelling attack occurs can vary rather greatly. So commonly infected areas, the subcutaneous attacks can affect the face, the extremities, the genitalia. The submucosal attacks can affect the oropharynx, the laryngeal area, as well as the gastrointestinal tract. The most common, 48 or so percent, are subcutaneous attacks, with abdominal attacks coming in at about 42% of all attacks. And fortunately, the laryngeal attacks, only in approximately 2% of all attacks does that occur. 50% of individuals with HAE, however, will experience a potentially life-threatening laryngeal attack at some time in their life. And in fact, the first attack they may experience may be in their laryngeal area. What causes this? The first symptoms we know can begin in very early childhood. It turns out that about 50% of individuals will have their first swelling attack by the time they're 11 years of age. Around puberty, particularly for young women, the incidence increases, and by age 20, approximately 99% of individuals with hereditary angioedema type 1 or type 2 will have had a swelling attack of some type. The common triggers are quite varied. The most commonly reported trigger, interestingly, is emotional stress. But we also know that trauma to the skin, medical procedures, including surgery and dental procedures, or even endoscopy, estrogens in women, use of ACE inhibitors can all be triggers for attacks of HAE. This is a rather comprehensive slide, but shows basically the complement pathway as well as the contact activation pathway. We've left out the coagulation pathway, which is also linked to this through factor 12. This disease got its name from lack of a C1 inhibitor, which we relate to the complement pathway, basically keeping C1, once it's activated, from flowing on down the complement pathway and activating the membrane attack complex that we're so familiar with, that's important in treating infectious disease. The contact activation pathway, however, starts with factor 12, Hegeman factor, also an important factor in the coagulation pathway. When it's activated by one of those triggers I mentioned, factor 12A is produced. Factor 12A has the ability to cause prekallikrein to convert to plasma kallikrein, which is attached to high molecular weight kininogen. Unimpeded by C1 inhibitor, the regulatory protein for this pathway, that kallikrein is then cleaved and bradykinin is released. Bradykinin attaches to a bradykinin B2 receptor, as you can see on the vascular membrane. That causes the blood vessels to dilate and begin leaking fluid, causing localized angioedema, hence the name of the disease. C1 inhibitor is active in a variety of other places in the pathway, both in the plasminogen pathway as well as in the fibrin degradation pathway. But when it's absent, then things can happen, and specifically in this case, bradykinin is produced in excess, and swelling occurs. This is just a comparison between the sort of pathophys, if you will, of a mast cell-mediated angioedema. The most common, probably 95% of all angioedema that we see in our offices is related to a mast cell event, whether it's a specific allergic event involving IgE or a direct mast cell activation with a medication. We are all very familiar and have been schooled for years on how a mast cell reaction might occur either from an allergic standpoint or non-allergic standpoint. The mediators for that are histamine as well as prostaglandins, leukotrienes, et cetera, that we are all very familiar with. Most of the time, mast cell disease presents with urticaria associated with the angioedema, but you can have a mast cell mediated problem without urticaria occurring at the same time. Below that is the pathway that we just looked at, the contact systems, beginning with Hageman factor activation, production of kallikrein from prekallikrein, and then release of bradykinin attaching to the bradykinin B2 receptor causing angioedema. So this is looking at a class. I'm going to go back one slide if I can. I can't go back. Thought I would. There it is. This is a classification or breakdown of the various types of hereditary. Oh, it's going to go back now. So comparing these two diseases, as I mentioned earlier, mast cell angioedema is often associated with urticaria. Urticaria is typically not associated with HAE or bradykinin-mediated angioedema. The family history, well, see how far, I guess it's a slow response here to my computer. Apologize for this. We'll stay on this slide. We're good. So urticaria is often associated with mast cell disease. Urticaria is not associated with bradykinin-mediated disease. Rapid onset of symptoms with mast cell disease, a slow onset and a slower offset of swelling related to bradykinin disease. No response to the typical drugs that treat mast cell reactions, epinephrine, corticosteroids, antihistamines, in individuals that have bradykinin-mediated disease. So with that little bit of history, you can begin to dissect or pick a pathway of which direction you're going to try to work this individual up. Are you going to look for bradykinin disease, or are you going to look for a mast cell mediated angioedema? This is a classification of hereditary angioedema, and it's quite broad, but the most common and the most well-studied is hereditary angioedema with C1 inhibitor deficiency or dysfunction, labeled C1-INH-HAE. It's due to one of 800, almost 900 now known mutations in the SERPINE1 gene. And again, type 1 is a deficiency in C1 inhibitor. Type 2 is a dysfunction of C1 inhibitor, but both diseases present the same way and are treated the same way. HAE with normal C1 inhibitor or N-C1-INH-HAE, we now know have a variety of different mutations that can cause it, and we're learning new mutations every day. So that unknown category down at the bottom is going to continue to produce more mutations as we are able to understand them. But there are a variety, and we do have genetic tests for factor 12, for plasminogen, for angiopoietin-1 and kininogen. Some labs will do the myofasciin and the heparin sulfate mutations. And in fact, there's 2 new mutations that are not even on this slide. But if you have somebody who has what typically looks like bradykinin-mediated disease, but normal laboratory ruling out HAE with C1 inhibitor deficiency, then genetic testing may be useful in elucidating what type of HAE they might have. So to that point, looking at diagnoses, again, you can do that by your history. What does it look like? Recurrent swelling of the skin. It's usually asymmetric. Again, a variety of things can be affected. The abdominal attacks may be misdiagnosed as surgical events or a bowel obstruction or appendicitis or other sorts of things. We know that there is a family history at 75% of individuals with HAE type 1 or type 2. The onset is usually before the age of 20, again, 50% before the age of 11. Patients can have recurring abdominal symptoms, which they may not even relate to the fact that occasionally their hand or their face or their tongue swells up. Typically in mast cell edema, we don't see laryngeal edema, but it is seen with some regularity in hereditary angioedema. And as I mentioned earlier, HAE is not responsive to antihistamine, steroids, epinephrine, or omalizumab, which can be, again, another test to see if you can rule out individuals with mast cell disease when they're not responsive to high levels of antihistamine therapy. Some patients, maybe 50%, do have prodromal symptoms, and as I mentioned earlier, bradykinin-mediated edema is not associated with urticaria at the time of the swelling. Now, these individuals, just like 20% of the population, can have urticaria, just like you and I can, but it's typically not related to the swelling episodes. So this is a little bit of a diagnostic algorithm that you can, if you have a clinical suspicion of HAE from your history, then I think as allergists, we can take the next step to do the laboratory that's listed here, a C1 inhibitor level, as well as a C1 inhibitor function, and a C4 level. It turns out with lacking C1 inhibitor, the complement pathway runs sort of unregulated, and C4 is diminished. If those labs show a reduction in C4, C1 inhibitor or function, then we are concerned that the patient may have HAE type 1 or type 2. If all those labs are normal, then we're over in the orange box with the normal C1 inhibitor HAE, and then genetic screening for mutations that we know of may be useful. So this is just a real quick grid on how these labs look in HAE type 1, type 2. In both situations, the individuals don't have enough functional C1 inhibitors. So when C1 inhibitor function is low in both type 1 and type 2. In type 1, they don't make enough of the protein. It doesn't fold up properly, so it can't get out of the cell. So the C1 inhibitor protein level in type 1 is low, but in type 2, they make plenty, but it's not functional. It doesn't work. Then if you look at the C4 level, which is sort of a measure of activity, if you will, that's diminished in both type 1 and type 2 because functional C1 inhibitor is absent. All the labs, Quest, LabCorp, et cetera, and even some of the specialty labs have this panel that you can order quite easily, and it's actually not terribly expensive. If you do get results that don't make sense or results that suggest HAE, we do recommend that the test be repeated one time to be sure there wasn't some lab issue that caused the test to be abnormal. Again, that's basically what I just said. You can do genetic testing looking for the known SERPING1 variants, but as I mentioned, there's, I think, 900 recognized now, and possibly the only time that you might want to look for a specific mutation in the SERPING1 gene would be in a situation of an infant or a young child whose lab may not make sense. You know what the mutation for the parent is, and you can look for that specific mutation in the child, and if they've got it, then despite what their lab may show, they will eventually have manifestations of hereditary angioedema. So we do, speaking of children, recommend that once you've made a diagnosis of hereditary angioedema in a family member, that individuals in the family be tested. So immediate family, grandparents, parents, siblings, children, and even grandchildren should be screened. The issue is that a delay in diagnosis can not only increase morbidity for the patient, decrease their quality of life, but also could be life-threatening and or fatal. Again, if the first HAE attack is laryngeal, nobody recognizes that, tries to treat it with epinephrine, and doesn't pay attention to the airway, the patient may succumb to asphyxiation. I've had one patient who, a 6-year-old, who her first attack was a laryngeal attack, and fortunately was recognized and treated properly. So what tests can you use? C1 inhibitor function, the protein levels that we talked about earlier, and the C4 levels as well. Typically, these are stable and predictive over the age of 1. Below the age of 1, the levels can be unreliable. So in those individual genetic testing, if you want to know child is already having symptoms, genetic testing may be useful. So then once you've made the diagnosis, what comes next? Well, one, individuals with HAE need to have a way to treat attacks when they occur. So on-demand treatment is prescribed sort of immediately, if you will. And then if the individual is significantly burdened by their attacks or anxiety about when is the next attack going to occur, et cetera, then we can have a discussion about preventive or prophylactic therapy ongoing. So our whole job, if you will, as physicians is to reduce the burden of disease on our patients. And that doesn't matter whether it's allergic rhinitis or food allergy, or in this case, hereditary angioedema. And fortunately, we've got some tools to be able to do that relatively effectively in this disease that affects only about somewhere between 8 and 10,000 individuals in the United States. 300,000 to 400,000 worldwide, but that's out of 7.6 billion people. So ultra orphan disease, but we've been able to develop some therapies that are very effective for controlling and preventing attacks. So the disease burden is really more than the attack, but it's how the attack affects your life, your quality of life. How does it affect you during the attack, and how does it affect you between attacks? Are you anxious about what's going to happen next? Are you depressed about the fact that you've got um, a chronic disease? When you have an attack, where are you? Where does the attack occur as far as in your body? How long are the symptoms going to last? Do you have to go to the ED to get treatment because you don't have your on-demand treatment with you? And just the disruption of life caused by the attack. Just as anecdotally, before, I've been doing this for 40 years, and we really didn't have HAE-specific therapy until 2008. So do the math. It hasn't been a very long time. And before we had specific therapy, we did have androgen therapy, but caused a lot of side effects. About 50% of my adult patients with HAE were on disability. These are young people or older people, but most of them, 50%, were on disability because they couldn't hold a job. They weren't able to finish their education. They couldn't get a good job. And they'd modified their life rather dramatically to cope with the disease. I can say now that with specific treatments, I think I only have 5% of my patients that still are disabled and are on some type of social security disability for this disease. So we've come a long way treating the burden. But we also need to think about the patient's caregivers, the individuals, the parents, spouses, others around the patient that have HAE, and how that really affects their life as well. So we're not just dealing with the patient's disease. And you can see on the left side of your screen the percentage of caregivers and what HAE tasks they're basically having to perform. Everything from what you might think, taking somebody to the doctor, talking to the doctor, preparing the medication, but also making treatment decisions for the children and adolescents and even some adults that have the disease. So it's lots of things that go along with just dealing with the disease, but then not having help to do household duties, not having help to do other activities of daily living. If you look at on the right side of the screen, some comments made by caregivers about their burden, if you will. I have to schedule my life around this patient. I have to deal with their medication, whether it be an infusion or injection. I'm trying to coordinate their medication so it's available when they need it. I often have to go to the hospital, on and on and on. And you can see that a lot that the green is strongly agree, and there's some things that caregivers have a significant concern about. So don't forget about them when you're talking to your hereditary angioedema patient. This is a disease that affects the whole family. Now, we do have validated tools for assessing the activity of the disease. One of them is the angioedema control test. This is similar to the asthma control test that we are all very familiar with. And it's a fairly easy test to apply. It goes from a score of 0 to 4, and there are 4 questions. How often have you had swelling? How much has your quality of life been affected by your angioedema? How much has the unpredictability of your angioedema bothered you? How well has your angioedema been controlled by your therapy? A score of 10 or below is considered poorly controlled. This is out of a number of 16 as a possibility. So this is a quick and easy way to kind of get an idea from the patient, just like we do with our asthma control test, sort of how they're doing. It actually can start or be used as a conversation starter at their visits in your office. So one of the things we treat people with, other than just giving them medications, is advice and understanding with the patient what their particular triggers are and what they can do to avoid them may well improve their attack frequency, but also their quality of life in general. So some obvious things are we don't want women who have HAE to take estrogen-based hormone therapy or birth control pills. We don't want individuals with HAE to take ACE inhibitors. We need to make sure that when the patient has some type of a medical or dental procedure, an endoscopy, an intubation, or something more serious, that they are pre-treated with something that will prevent an attack, because we know trauma can certainly cause an attack, and trauma around the airway can lead to laryngeal attack and closure. We also know that there are other things that can trigger attacks, again, stress, viral infections, particularly with fever, minor trauma, and just being overworked or over fatigue can drive this. So now let's talk a little bit about treatment for the disease. As I mentioned, we've really come a long way from 2008 when the first drug was approved, a replacement therapy for C1 inhibitor that had to be given every 3 days. We've come a long way from that. So the strategies, as I mentioned earlier, were you got to be able to treat attacks. So on-demand therapy stops attack. We recommend that every attack be treated and be treated early in the attack. We recommend that all patients have at least enough medication to treat 2 attacks, and that they should have that sort of on their body or with them most of the time. It shouldn't be sitting at home 3 hours away from their work. If patients are having events that might cause an attack, like surgery or a dental procedure, then using short-term prophylaxis before the procedure to prevent attacks is very appropriate. Then long-term prophylaxis, which may be something that upwards to 75% of patients may opt for, to just totally decrease the attack burden, try to decrease not only the frequency and severity, but also the need for on-demand medications. And obviously that's something that can be discussed in a shared decision-making situation. Everybody is different. Everybody's treatment's got to be individualized, again, just like we do with our patients with allergic rhinitis or asthma or food allergy. We've got to know what their issues are and try to meet them where they are and provide ideas and therapies based on that. So these are recommendations that on-demand therapy access is important, that all attacks should be considered for treatment regardless of site or severity, meaning the attacks that may start in your little finger may progress to involve your throat. So why not just shut it off when the system is off-regulated and an attack is starting? Most patients can self-administer rather than having to go to the ED or a clinic to receive an IV or subcutaneous injection. We've talked about prophylaxis, short-term and long-term. In HAE with normal C1 inhibitor, there's some evidence that common medications like progestins or antifibrinolytics may be helpful in prophylaxis in that particular individual group. We'd like to prioritize individuals' quality of life. Again, pick the first-line therapies, and these are somewhat based on age. We'll talk about that in a minute. Again, avoid estrogens. If woman does become pregnant, we currently prefer a C1 inhibitor replacement therapy as opposed to one of the other medications that attack the pathway in different areas. This is sort of the timeline of the development. As I mentioned, the first drug that was approved for C1 inhibitor hereditary angioedema was back in 2008. It was a concentrated C1 inhibitor that had to be given every three days. Most of the patients self-administered. In 2009, we got 2 on-demand therapies, a C1 inhibitor that could be given when an attack occurred, and another drug, encalantide, which was a plasma kallikrein inhibitor, so blocked the pathway sort of halfway down. It was approved for age 16 and up, but unfortunately with a boxed warning because of anaphylaxis that had been seen in the clinical trials, suggesting that the patient only received this from a healthcare provider, making self-administration not an option and much more difficult to receive this drug. 2011, icatibant, again, for on-demand therapy, approved in the United States for 18 and above, was a subcutaneous agent to block the bradykinin 2 receptor, so all the way down at the bottom of the pathway, preventing bradykinin from causing vasodilation. Then we had a recombinant C1 inhibitor, a non-plasma-derived C1 inhibitor approved in 2014, age 12 and up. Excuse me. And then in 2017, we went from IV C1 inhibitor replacement to sub-Q C1 inhibitor replacement, similar to sub-Q IV or IG, making it much easier for the patients to treat, and actually a more effective drug because of the stability of the amount of C1 that was in the system. A year later, lanadelumab, which was the first monoclonal antibody, was approved for age 12 and up. And then in 2020, we had the first oral preventive medication, berotralstat, again approved for age 12 and up. That year, the C1 inhibitor prophylaxis, the sub-Q, was dropped to age 6. And then actually 2 years ago, we had an approval extension for lanadelumab down to age 2, where patients as young as age 2 could receive that prophylactic agent sub-Q. We've had 2 drugs approved so far this summer, garadacimab, which is a factor 12A inhibitor, so it works right at the very top of the pathway for prophylaxis, and sebetralstat, which is the first oral on-demand medication for individuals age 12 and above. So that's kind of what we've done. As you can tell, we've been quite busy over the last 20 years developing these medications. So this is looking at the pathway again, sort of in a different direction, but shows you where the various on-demand drugs work. C1 inhibitor in a variety of places. The sebetralstat and encalantide are plasma kallikrein inhibitors, and the icatibant working down at the bradykinin 2 receptor for treatment of attacks when they occur. This is some data from C1 inhibitor replacement from the early trials with IV C1 inhibitor. We looked both at a 10 unit and a 20 unit per kilogram dosage. The 20 unit is what's approved in the United States and had a significant impact on frequency of attacks, seemed to be quite, or seemed to work very quickly. And you can see the time to symptom onset of relief was about 3.89 hours versus 10 hours for the placebo-treated patients with a 20 microgram. So this is still a viable therapy for on-demand therapy. Is typically what is available in emergency rooms and in hospitals when patients present for treatment of an attack. It's given intravenously over a period of about 10 minutes, and again works relatively quickly. It's safe, well tolerated. There's been no seroconversions for AIDS or hepatitis or a human B19 virus with this product. What I do? Going back. This is the study with encalantide. Again, looking at its onset of action and change of basically a symptom score in individuals with treated either with encalantide or a placebo at time 4 hours. You can see that there was a 50% sort of decrease in the total symptom score with encalantide, where there was really no significant change in the individuals treated with placebo. Again, no deaths, no treatment-related SAEs, no withdrawals, but again, the issue with anaphylaxis occurring in 2 to 3% of these individuals precluded it being approved for self-administration. Encalantide, or rather icatibant, which is used to be a branded drug, is now generic, is a probably the most commonly used on-demand drug in the adult population in the United States and in the entire HAE population worldwide. It's a subcutaneous injection, and in this study, the FAST-3 study, showed that median time to onset of symptom relief for the icatibant group was 2 hours versus 20 hours for the individuals treated with placebo. The challenge with this drug, again, is it's a needle and an injection. It actually burns and hurts quite a bit. Patients do not like it, but it does work very well. And as far as side effects, there's really no significant issues related to it that we're aware of. And as I mentioned, it now is in a generic format. So this is data from the most recently approved drug, the oral on-demand drug, sebetralstat. And what you can see in these graphs, this is on the far left is the beginning of symptom relief, which was the primary endpoint in this study. And both the 300 and 600 milligram dosage showed really, if you look at the graph, at 50% of attacks had already begun improving within about 1.6 hours of administration of the drug, compared to the placebo, which was out at about 7.5 hours. If you look at reduction in severity, again, the sebetralstat active drug significantly decreased severity and more frequently than the placebo group did. And looking at complete resolution, again, much more rapid with following administration of sebetralstat. This drug was approved about a month ago. The 600 milligram, which will be 2 tablets, dosage was what was recommended by the FDA, and it's approved down to age 12, which fills a need that we didn't have filled before. Again, before sebetralstat, we had encalantide, which you had to get from a healthcare provider. We had IV C1 inhibitor, but that was it if you were under age 18. You couldn't self-administer icatibant. It wasn't approved for that age group. And it was really a difficult time for individuals under the age of 18 who had attacks. But with this, at least down to age 12, we now have a tablet these individuals can take when they swell. What about prophylactic therapy? So this is what we've sort of presented earlier. We can replace the C1 inhibitor that's missing, so the pathway is regulated. And you can see where that sort of works in the pathway. We can block plasma kallikrein. We can do that either with a monoclonal antibody, or we can block it with an oral medication. And now we have a factor XIIa antagonist that blocks the pathway from even getting started. If we look at the data for these drugs, this is from the sub-Q C1 inhibitor study, the compact study, and the 60 international unit dosage is actually the approved dosage. And you can see compared to the placebo patients, the individuals that had moderate and severe attacks were much greater than the individuals treated actually with either 40 or 60 IUs of a C1 inhibitor. This is the monoclonal antibody, lanadelumab, and the study was known as the HELP study. The approved dosage is 300 milligrams every 2 weeks for individuals age 12 and above. Although the lower doses you can, in the less frequent interval, the 150 4 weeks and 300 every 4 weeks do work, but you can see that there's about, compared to placebo, about an 85% decrease in attacks in individuals that are on the 300 milligrams every 2 weeks compared to the placebo group. Again, if you look at attack severity, individuals that on all 3 doses had a decrease in moderate and severe attacks compared to the placebo, which had really no change in those types of attacks. This is the oral plasma kallikrein inhibitor, berotralstat. Again, the graph shows investigator-confirmed attack rates. This is a mean of them. And 2 doses of berotralstat, 110 and 150 versus placebo. The placebo's in gray. And you can see we're really within the first few weeks, and certainly at 1 month, there's a significant difference between patients treated with the 150 and the 110 versus placebo. The recommended dosage is 150. It's a tablet taken once a day, preferably with food, on an ongoing basis. And this drug has been shown to be very effective in many patients, but not as effective in others. And that may well be just a dosage, a concentration problem. We can't push the dose above 150 because of some QTc interval issues that might occur in certain individuals. The Vanguard study was the study that was just completed for garadacimab, the factor XIIa inhibitor. And again, you can see these are mean differences on the left side in attack frequency. So individuals on placebo are all over the map, but the average attack rate during the trial was about 1.2 attacks per month. In the garadacimab group, the attack frequency was about 0.1 attack per month. And actually, if you looked at the median, it was 0. There was a 100% decrease in attack rate. If you looked at the medians, about 87, I think, percent, maybe even a little bit more than that, if you looked at the means. If you look again on the right side, and this we haven't looked at before, but this is just sort of the percentage of patients that responded with different decreases in attack frequency. So the blue is 50%, the green is 70%, the orange is 90%, and the purple is attack-free. And you can see in the garadacimab group, again, 95% of the patients had a more than 50% attack reduction. And as you go out, that percentage goes down a bit, but it nets out at about 87%. So again, a very effective drug. The main treatment adverse events were runny noses and respiratory tract infections, again, probably not related to use of the drug. Because this drug is part of the coagulation pathway, we were concerned that there may have been some bleeding or clotting issues, but that was not seen in the study. There is a little bit of an aberration with APTT testing, but that's a lab issue and not related, again, to bleeding or clotting. So if we look at the investigational therapies, and we'll wrap up here, there's one that's looking at it's going to be approved in another 2 weeks, donidalorsen. It's an antisense oligonucleotide that decreases the production of prekallikrein. So if you don't have prekallikrein, you can't make kallikrein. If you can't make kallikrein, you can't make bradykinin. We'll see. Phase 3 is finished. It's quite positive, and again, its PDUFA date is coming up on the 21st of this month. Deucrictibant is an oral bradykinin B2 receptor antagonist, so it's oral icatibant, if you will. It's now in its phase 3 trial, and it's being studied both for on-demand therapy as well as prevention, donidalorsen being primarily for prevention. And then really on the horizon, cutting edge, if you will, no pun intended, is the NTLA 2002 product that is a CRISPR-Cas9 gene editing that goes in and cuts out the prekallikrein gene. So the patient can't make prekallikrein, and so they can't make kallikrein and can't make bradykinin, just like the others that we've talked about. They finished and have very positive results in their phase 1b/2 trial, and now they're enrolling the phase 3 trial worldwide, which will include about 60 patients age 16 and up, to see if this is effective in that group. So this is basically showing where everything is from as far as the evolving landscape. You can see the drugs that we've been talking about in this cascade and where they work. Again, it's a wealth of good news. The donidalorsen and NTLA will work up on the prekallikrein production, as I mentioned earlier. So this is the donidalorsen data. Again, it's an mRNA antisense therapy, so it basically confuses the cell into making a nonsense prekallikrein that's not functional. It takes a while for it to start working, somewhere between 2 to 4 weeks. You can see the blue line there. every 8 weeks, or every 4 weeks is the dark one, 8 weeks is the light one. But because you have to use up the precalcrin that's existing already in the system, so it doesn't work immediately, if you will. You use it up, and once it's been used up, then you have a very stable decrease in attack frequency. And again, you can see the attack decreases around 90%, similar to what we saw with lanadelumab, similarly with what we saw with garadacimab and with the C1 inhibitor concentrate. The good news here is that we may be able, or a subset of patients may be able to dose every 8 weeks rather than every 2 weeks or every 4 weeks with the other sub-Q injectables. Again, you can see that display on the right side of what percentage of patients had what percentage of decrease in attack frequency. You can see there was a large number of individuals that had no attacks at all during the trial. This is the Decryptobant data, the oral B2 receptor antagonist. This is their prophylactic data in just phase 2, small numbers. So we're now awaiting the data from their phase 3 study, which is ongoing. But you can see that they had reduction in the same ballpark as the sub-Q drugs, 84.5% reduction in monthly attack rates, ditto over 90% reduction in moderate to severe attacks, and the same reduction in need for on-demand medication. So we're keeping our fingers crossed that this drug will show the same results in the phase 3 trial that is ongoing. This is the CRISPR-Cas9 data, the gene editing data. And you can, again, if you focus on the bottom half of that table, that looking at different time points, 1 to 16 weeks, 5 to 16 weeks. Again, it takes a while for the precalcrin to go away. So if you knock it out, you're going to really start seeing a benefit at about a month. And you can see the decrease in attack frequency is close to or above 90% in these individuals. That actually all 3 of the doses that they used in their phase 2 trial, the 25, 50, or 75 milligram. But again, small numbers, we'll see what things look like as we move forward. So practical recommendations, individualized treatment. We talked about that based on a lot of things, mainly burden of disease. And that could include attack frequency and severity, but also patient preference and other factors. Everybody needs to have an on-demand treatment, no matter how old they are. What that on-demand treatment is obviously needs to be age appropriate by approval. Consider long-term prophylaxis for patients that have frequent or severe attacks or have significant burden. It doesn't have to be based on the frequency or the severity of the attacks. It could be based on the disability that the attacks do cause. Recommend short-term prophylaxis before procedures when triggers are anticipated. And again, we want patients to be self-caring, so to being able to self-administer their drugs, which will improve their quality of life and also reduce treatment delays, particularly in the on-demand setting. So at this point, I'm not going to spend a lot of time on shared decision-making. Again, you all know that better than I do. Basically exploring the patient's needs and goals, discussing what the alternatives are that might meet those goals, and then develop sort of an informed preference, and then with the patient and or their family make a decision based on that information that you gleaned from the patient, that you provided to the patient about the therapy that you're recommending. And that obviously leads to usually a more adherent patient, adherent to medication, and hopefully optimal patient care and health equity. So again, an action plan, patients need to have a plan for all of these things. How are they going to access and keep and use their medications? When should they go to the hospital if something is not right? How do they use their medication? Being able to recognize signs and symptoms of HAE early so that it can be treated early, and then have a plan for travel, again, access to medications. Now, I'd like to turn this over to Dr. Kolinsky at this point, and he's going to present a very interesting case that has some polling questions in it, so please participate in that, and I'll thank you for your attention to my piece here. Nick?
Thank you, Dr. Lumry. You're a great teacher. That was super informative. So this is a case that we actually saw at the Allergy, Asthma, and Immunology Center. 14-year-old girl comes in with recurrent angioedema. It's recurrent, non-pitting, doesn't itch, there's no urticaria. Episodes began around the age of 8 or 9, but now they occur more frequently, increase in severity, occur about every 1 to 2 months. She can have swelling of her abdomen. She's had to miss multiple days of school. She was sent home for GI distress. She's had disfiguring edema of the face, lips. It's really impacted her day-to-day life. Her attacks typically develop over 24 to 48 hours and then resolve over a 3 to 5 day period, typically triggered by stress and puberty. And this is an important part of the history. It does not improve with antihistamines, epinephrine, or steroids. Next slide. So other parts of her medical history, she has runny nose, stuffy nose. She's never had any allergy testing done. She uses an over-the-counter nasal spray, fluticasone, 1 to 2 sprays each side twice a day. She is on a birth control pill. She's never had any laryngeal attacks, never been admitted to the hospital, but has visited the ED multiple times because of her angioedema attacks. Next slide. So here's the first polling question. Which feature is most suggestive of HAE or hereditary angioedema in this patient? Is it the recurrent abdominal pain? Is it lack of response to antihistamines, epinephrine, and steroids? Is it puberty as a trigger or chronic rhinitis? And we'll give you an opportunity to respond. So I can't see the most common answer, but I'll tell you what I think it is. The lack of response to antihistamines and steroids. And just like my patient, oh, here we go. It looks like 100% of the individuals that answered, 8 out of 8 said B, lack of response to antihistamines and steroids. I would agree. Dr. Lumry, what do you think?
Absolutely. Good job, everybody. That's
Yeah, they
an
nailed it first try.
important one. Nailed it. Absolutely.
Next slide, please.
Yeah, I can get it to advance. Whoops. Okay, we discussed that. Yeah, I mean, we've talked about other uh, things that might be on that list, like lack of urticaria, the duration of attacks, the uh, uh, again, importantly, the lack of response to medications. Nick, what other kinds of things might you think about in your while you're taking a history that might suggest this disorder?
So for this patient, it was almost like she read the book to me as far as the onset, the duration, been to the ER, urgent care multiple times. She never felt like the steroids or antihistamines were working. And it kind of gets your brain churning like, hey, maybe this isn't histamine driven angioedema. There could be something else going on. I'll get in some other details here in a minute that will kind of show you there's other things that I learned from the history that also kind of steer me in the right direction. So it was a really interesting case. So other parts of the social history, she's 14 years old. She doesn't smoke or drink alcohol, no drug use. And it turns out upon further questioning, her mother also has these recurrent episodes of angioedema, had never been worked up, typically was worse for her during the same time, during puberty, and then also during pregnancy. So this is an interesting part of the history as well. Next slide. She had a normal exam other than what was described in her history of present illness. Next slide. So on physical exam, she had clear conjunctiva. I saw Denny Morgan lines. She had moderate allergic shiners, swollen pale turbinates, otherwise normal physical exam. She did not have any angioedema at the time of the office visit. Next slide. So here's the second polling question. What type of testing would you order for this patient? C4, C1 inhibitor level and function, the hereditary angioedema focused gene panel, next generation sequencing, which is GNANG genetic testing, an allergy skin test, or a CT scan of the neck and the chest. All right, so it looks like we have 83% say option A, 17% option B. So I would have to say what we would typically do is get a C4, C1 inhibitor level, and C1 inhibitor function. Just like Dr. Lumry mentioned, the genetic testing, like you had said, if the patient had initially had maybe normal labs, but a really convincing history, it may be reasonable to consider that as a secondary option. But I think the most practical is option A, an allergy skin test. She does have allergic symptoms, and that may be a test that I do order. But as far as a reason for her recurrent episodes of angioedema, probably not really helpful.
I would agree
Next
with
slide.
that. I mean, the genetic test is not necessarily the wrong answer. In fact, if you were in Europe, you might get that test because it's easier to get it paid for over there than the serological testing. But here in the United States, certainly we can get the serological tests quicker and cheaper in most settings than we can get approval for a next-gen sequencing genetic test.
Definitely, I think under the right circumstances can be very helpful.
Yep. So I'm trying to advance it now. I guess whoever can release it from the question. No. Okay, that's our discussion. Again, we talked about that. So yeah, I'll let you go forward here.
So here's what we ordered. So we got our C4 protein level, C1 inhibitor level, and C1 inhibitor function. You can see the result in the normal range. It looks like all three were low. So think about the presentation that Dr. Lumry just gave. What would this be? Is this hereditary angioedema? If it is it type 1? Is it type 2? Is it HAE with normal C1 esterase? So what do we think about that? You can go to the next slide.
So did we?
So,
go ahead.
I was just going to say is that I think that this is a reasonable place to start. All three are low. So correct me if I'm wrong, but I remember from your presentation, this should be HAE type 1, correct?
Yes. Yes.
Okay, great. And I think that if the C4 were low, the level is normal or high, but the function is low, then that would be HAE type 2.
Correct.
Perfect. Next slide, please. So here's another polling question. The patient is diagnosed with HAE type 1. What type of on-demand treatment would you prescribe for the patient? C1 inhibitor, icatibant, ecallantide, or sebetralstat? And again, we'll give you a moment to answer. This is a 14-year-old female.
Interesting.
Okay, so we got a mixed bag here. So there were 8 of you that answered. 2 of you said yes to each one. So 25% across the board. So that's interesting. So let's kind of walk through this. So 14-year-old female, could we prescribe C1 inhibitor for an on-demand treatment option? Yes. Icatibant, I believe you said it was 18 years of age and older, correct? Here in the
Correct.
United States, at least.
Yes.
So then that one, we would maybe have a difficult time getting approved. Ecallantide, I know has a lower age indication, but it has to be administered typically in the office by a medical professional. So it might not be the most practical. And I think you mentioned potential anaphylaxis with this medication.
Correct.
So something to kind of think about there. And then we have the new kid on the block, sebetralstat, which I think could be a reasonable on-demand option. Dr. Lumry, do you have any opinion on which one you would maybe pick and why?
Well, I do. Again, this was an unmet need for these kids, age 12 and below age 18 up to, and basically we had an IV. So the C1 inhibitor has to be given IV, which there's significant burden to that. If the child can't start her own IVs and the parent has to, or they have to go to the hospital or an emergency room to have an IV started and treated. You mentioned Takeda not being approved, and it's hard to get the insurance to allow patients to have medications that there's not a approval by the FDA for. The issue with encalantide, again, not easily obtained. Hospital, clinic, or have someone come out to your house, a nurse, to observe you after you're treated, to be able to treat an anaphylactic reaction should it occur. And then there's sebetralstat, which I think of the four has the least burden of treatment. This is something the patient can take herself, swallowed, no shots, no needles, and can take it very early so that she doesn't have to wait to get to the ER. She doesn't have to wait to have somebody start an IV. And it is approved down to age 12.
Those are great points. Thank you. Next slide. All right, so which of the following would you prescribe for prophylaxis? So we just talked about our on-demand. What about the prophylactic medication? So C1 inhibitor, danazol, lanadelumab, or berotralstat? All right, so it looks like we had 13%, or 1 out of 8, say C1 inhibitor. No one said danazol, which I think is great. We had 2 out of 8, or 25%, say lanadelumab, and then the majority, 5 out of 8, berotralstat. So kind of starting from the top, so for a prophylactic therapy, C1 inhibitor, you could prescribe that. That's okay. You could prescribe that for this patient. Danazol, we would likely want to stay away from. I think that would be a last resort. Lanadelumab, I think, is a reasonable option. I think that would work well for the patient, as well as option B, as well as option D. Dr. Lumry, what do you think?
Well, I agree with that. Obviously, you're not going to be giving a male hormone to a 14-year-old pubertal girl. At least I hope you don't. The C1 inhibitor, again, if we talk about burden of treatment, has to be given either IV or sub-Q every 3 to 4 days. So there's some burden there, particularly for an adolescent. Lanadelumab, an injection every 2 weeks, moderately uncomfortable, but certainly an option. And then berotralstat being a daily oral medication. Again, some challenges around that with individuals that aren't used to taking medications every day. But in my experience, many of the new starts to prophylaxis are opting for an oral option, if you will, before being trained or begin using subcutaneous or other types of therapy. So I would agree that 3C1, Lana, or berotralstat are all appropriate for this age, all very effective. Then it's just a matter of talking with the patient and the family about what looks like the best option for this child.
Dr. Lumry, in your experience, do you think with a 14-year-old, do you think that they're usually going to take their medication by themselves, like the oral medication option D? Or do you think you rely on the parent to encourage the patient to take the medication? Or how do you address that when you have a younger patient like this?
Well, it's a challenge, as you know. Again, kids don't want to be different, and taking medication every day makes them feel different. So does getting a shot every 2 weeks, though. So I think you have to set up a routine for the patient, whether it's a pill box that by the day with their medication in it, whether the parents present it at dinner time every night, or how that's done. But certainly, if we're going to use an oral daily medication, we've got to come up with a plan for her to be adherent to that program, because we know that this drug, if it's not used regularly, doesn't work. So that's a challenge. Would pinning her down and giving her an injection every 2 or possibly every 4 weeks be another option that might be more successful? Again, it's all going to be sort of decided by the family dynamic and what the patient. I mean, she's becoming a little adult now, so she's going to have a say in the action, if you will. And I think we're going to have to work it out with that shared decision-making process to see which one might work best for her. What do you think?
Exactly. I agree completely. Gotta have to educate the patient, let them know about what their options are, maybe why you would encourage them to go one way versus another, but ultimately it's the patient's decision. And I think as long as we do our job informing the patient, we can use that shared decision making to where they're ultimately can help in their care. So those are really good points. We'll go to the next slide. All right, so what did we do? So our treatment plan, we started lanadelumab as her prophylactic therapy, Barinert for on-demand rescue. This was about a year ago that we saw this patient. So option D wasn't out at the time, so the patient ended up going on Barinert for on-demand rescue. Other medications, she was started on a nasal steroid spray that was also had a nasal antihistamine component to it. She had skin testing done. She ended up being very allergic to things in the environment, which we kind of thought from her history and then physical exam. She was started on allergy shots. And then, like you mentioned, Dr. Lumry, in your discussion or in your presentation, a family member was also affected by the disease. We know it's an autosomal dominant gene mutation. Turns out the mother also had symptoms. So we tested her as well. She was also type 1 HAE. And then we started her on the same treatment plan as her daughter. We felt like that was reasonable to where they could do their treatment together. We felt like they would both be more compliant by going through this together. Next slide. So at follow-up, we ended up switching the patient to the oral on-demand sebetralstat. We discussed the different options as far as what they could use. They both agreed that this was a better option for on-demand therapy. And now they're both doing really well, living attack-free. Thankfully, have not had to use their on-demand rescue, but they do have it. They think it's easier to carry, and there's not so much worry about carrying around needles or what other people may think. And they feel like they may use this on demand quicker because it is oral as opposed to using a different option where they might want to reserve it or they're worried about taking it. So they're doing well.
Yeah.
Next slide.
If I can get back here. Yep. So I'm gonna be the guy out or the woman out in the audience that's jumping up and down and raising her hands and waving them about what we've missed as part of this discussion and treatment plan. Nick, so what am I going to bring up? I'll give you a what am I thinking question.
Is it the fact that she's on birth control?
Absolutely. So what do you think about that? Or what did you do
So,
about that? Let's put that together.
right. So we know that changes in hormones, specifically maybe estrogen, can cause these types of angioedema attacks. If a patient is on a birth control product that has both estrogen and progesterone in it, then that patient may be at risk for having angioedema attacks. So switching to a progesterone only birth control option is reasonable. I think that that's something that you have to discuss with the patient. It probably depends on the severity and frequency of attacks or the shared decision making point of that discussion of what to do and how to address that. I think it's maybe not one right way to do it, but I'm curious to know how you approach that with your many years of experience. I think that you might have a very valuable opinion.
Well, we tried, thank you for that. We tried to avoid estrogens really at all costs. Now, does that mean that a woman who's menopausal, who's having issues, can't use a low dose estrogen patch if she's well controlled on prophylactic medication, blah, blah, blah? No, that's something that we can work out. But typically, for these young girls, I get their gynecologist involved or their whoever is taking care of that part of their care and talk about the options that estrogens may make her worse, that progesterone based drugs are will not make her worse. And that's something if everyone is comfortable with that we go to. The other piece, and this is sort of treatment burden issues, some type of depot progesterone therapy may actually be more appropriate for a 14-year-old, again, who's not used to taking medications on a regular basis, blah, blah, blah. So that would be another option. But we do try to stay away from women who are in their childbearing years with the estrogen-based contraceptive agents.
Really important point. I'm glad that you pointed that out. So thank you so much. Go to the next slide.
So thank you everybody for joining us. These are just sort of a quick run through of what we talked about. Basically, this is a rare disease, but thinking about it, a suspicion of the disease will help you make a diagnosis. I know many of you may never have seen any of these patients, just heard about it for a day or a half a day in medical school. But as long as if you're looking at patients that have had angioedema without urticaria, it's surprising how many folks with a bradykinin-mediated disease such as HAE will be found. We've talked about the diagnostic tests. The easy ones are C4, C1 inhibitor level, as well as function. But if those are all normal, then looking for HAE with normal C1 inhibitor makes a lot of sense. You can do that with genetic testing. And again, the different genetic diseases that seem to be identified now that cause that is expanding every month, literally. We need to target disease impact, burden, if you will, both on the patients as well as the caregivers, with everybody having access to on-demand therapy and then adding prophylaxis in patients that are more burdened by their disease. Again, the treatment landscape continues to evolve. I think this is one of the few rare diseases that we have as many treatments as we do. There are now 10 approved and 6 more in the pipeline. So a plethora of very effective, safe medication for these individuals, allowing them to lead near normal lives now, which is something that was not even something that we could dream about 20 years ago. Obviously, everybody is different, and with all of our patients, the treatment that we provide and advice we provide needs to be individualized to that particular patient, and then using shared decision making and other tools, be able to assess the impact of the disease and assess where the patient essentially wants to go with their treatment. So that's sort of what we tried to do. I think the case that Nick presented was very appropriate. It's very typical. And again, particularly the fact that the mother had this all her life and nobody had ever thought about it. Or maybe she never complained about it. She just thought that the fact that she threw up every time she had a menstrual period and laid in bed for 5 days was normal. But again, once you make a diagnosis, you need to look around because you're going to find other individuals in that family that have the disorder. So we have some time for question and answers if we want to jump into that. I don't know how to bring those up. Are there any in the chat, or how do we get there? No.
There's one question in the Q&A box. I can read it out loud if you are having trouble
Please
finding.
do. That would be great.
Of course. So the question says, adolescence is a difficult stage of development for any individual. What are some specific psychosocial challenges that adolescents living with HAE are likely to encounter? And do you have any suggestions as to how to help them navigate them?
Nick, since this is your patient, she's certainly right in the smack middle of her adolescence. What have you done with her and her family to help?
Sure, I think first educating them on the disease, helping them understand what the expectations are of their treatment plan, and then understanding what it would be like to actually administer and use the prophylactic therapies ourselves, what it's like going through that, the on-demand therapies. I think especially the on-demand, I would imagine if I was a teenager or in middle school, and if I had an angioedema attack, it probably is one, uncomfortable, but then two, the patient might be being made fun of while they're at school. It can be very disfiguring. They can feel very uncomfortable with those abdominal attacks like you're describing, having to leave school often. Maybe they're ashamed or worried what they're going to look like if they use their rescue medication So they might delay the use of that rescue medication. So there's all those kind of things that you want to think about. You kind of have to put your shoes back in, or get back into their shoes and think what it was like when you were in middle school or when you were that young. But those are just a couple of those kind of factors. Dr. Lumry, what do you think?
Absolutely. Again, nobody wants to be sick, but particular or different, but particularly adolescents don't want to be different. And to have a disease that might show up one day where your face is all swollen up, or you're at class and you start having a swollen belly and have to leave the room and vomit, and it's a very hard reality for these kids. And I think minimizing the attacks, and in your case, you put her on a prophylactic therapy, making her treatment of attacks when they do occur discreet. She doesn't have to go to the nurse's station to get a shot or go to the hospital to get an IV. She can go take a couple of tablets now, even without water, and go on with her life. Is really the way to attack this, particularly in this age group, or frankly, any age group, but particularly with adolescents who don't want to be different. You don't want to set up barriers for her taking treatment. I'm not going to do that because it makes me different. So I think that the program that you put together for her is very appropriate, and one that I think we're going to see again. I'm so excited that we've sort of filled one of the unmet needs in this adolescent population by providing an easy to use, sort of non-invasive on-demand therapy for these kiddos that heretofore have had to get IVs or just suffer through their attacks, or have somebody come out and watch them for a couple of hours if they're treated at home. This is a huge advance. So yeah, that's how I think about approaching an adolescent. Again, they don't want to be sick, but hey, we've got drugs that'll make you just as almost as normal as everybody else, and ways to fix it if you do happen to break through and have an attack. And I think the kids will appreciate that.
Definitely. And like you said in your slide deck, the goal with these HAE patients is to normalize their lives, make them feel like everybody else,
Yeah.
like they're attack free. And so really important to keep in mind.
Great. Well, if there are not any other questions, we're a little bit over time, but thank you all for attending. Thank you for your participation in the question and answer. Thank you to Integrity CE for hosting the event and putting together this nice presentation for us. And Nick, thank you for your excellent case presentation. That was just perfect.
Thank you, Dr. Lumry. It was a pleasure.
Good night, everyone.